Good day, I am Marbini Ibrahim Abdul Singh. I'm working in College Department in Cancer Care Treatment Rooms. Today I'll be using lecturing and audiovisual as my teaching strategy in nursing education. I will present some information for the nurses who's working in College Department and nursing students who willing to work in oncology. This is about chemotherapy and biotherapy. Objective: at the end of this class, the nurses will be able to define malignancy, identify virus treatment option for malignancies, differentiate between various chemotherapy classes, interpret biotherapy mechanism of action, management symptoms caused of various treatment modalities, participate in management for all patients presented to oncology department, administer chemotherapy and biotherapy safely, and proper documentation. So, cancer cells. Cancer cells have characteristics. It is abnormal cell proliferation, lack of controlled growth and division, ability to spread metastasis, and invade other tissue. Can involve any body tissue, invade natural cell death called apoptosis. So we have grading and differentiation of the tumor. So GX is a grade cannot be assessed. G1 is a well differentiated. This is usually an early detection, and the survival rate of the patient is higher. G2 moderately differentiated. G3 is a poorly differentiated, and G4 is undifferentiated. For the G4 undifferentiated, maybe the tumor is already metastasis, and the disease progression of the patients is very poor. So we have the staging, we have the T and M. If we say T and M, we have the tumor, the nodes, and metastasis. For the tumor, there can be a local involvement. The nodes, we have the lymph nodes involvement, and metastasis is the distance location. For the international TMN staging system, or the tumor, the node, metastasis staging system, we have the stage 1, stage 2, stage 3, and stage 4. As you see, in stage 1 is an early disease, tumor confined to the breast, so there's no involvement of the node. So it can be an early detection, and the survival of the patient is higher. For the stage 2 is an early disease tumor spread to movable ipsilateral axillary nodes, so there can be an involvement of some nodes of the breast. And the stage is locally advanced disease tumor spread to the superficial structure of the chest wall, a movement of ipsilateral internal mammary lymph nodes. So there can be involvement, the lymph nodes and the chest wall of the patient. And the stage 4, it is advanced or metastasis. Disease present at distant sites such as bone, liver, lungs, and brain, and including supraclavicular lymph node and involvement. So the staging of this patient, the prognosis is very poor because of the metastasis from a different part of the organs of the body. So we have the treatment option, we have the surgery, the radiation therapy, the chemotherapy and hormonal therapies, biotherapy and targeted agents such as hormones and vaccine. For the goal of the cancer therapy, it can be prevention, for the cure, control, and palliation. So the principle of cancer therapy, we have the adjuvant, neoadjuvant therapy, chemoprevention, myeloablation is a bone marrow and stem cell transplant, and immunosuppression, we have the stem cell transplant. So we have a different classification of antineoplastic or anti-tumor drug. So they are alkylating agent, antimetabolites, anti-tumor antibiotic, nutraceureas, plant alkaloid. We have the capotocin, the epidomylotoxin, the taxine, the vincal alkaloid, and we have the miscellaneous. So why we are wearing PPE? So we have to do double chemotherapy test glove, protective gowns, and protective eyewear. If there's a potential for splashing, should be worn whenever handling hazardous drug that will include chemotherapy or contaminated item, example during administration materials and body fluid exposure. So these recommendations are based on the increasingly strong research indicating the surface and the air contamination occurs throughout the chemotherapy preparation, administration, and disposable areas, and that those who work in this area can be exposed repeatedly or this agent at low but chronic level. So unlike radiation exposure, exposure to hazardous drug cannot be measured with a bench or device. So we don't know how much we're already exposed to a certain drugs. Instead, healthcare worker must strive to minimize exposure to this drug in addition to engineering control, safe work practice, and the use of personal protective equipment. Then healthcare workers should be routinely monitored in a medical surveillance program. ONS is what we call Oncology Nursing Society, the Occupational Safety and Health Administration, or OSAHA, and the American Society of Health System Pharmacy, the ASHP, all have recommendations related to employee medical surveillance. So, yearly or annually, we have to monitor ourselves for signs and symptoms so we can check over it, what is happening to our body after exposure to the hazardous drug or chemotherapy drugs. So let's talk about cell cycle. So cell cycle, we have the metaphase. Under this, we have the prephase, metaphase, anaphase, and telophase. That will be called the M phase. We have the G1 phase, the first growth phase. We have the growth and normal metabolic growth, and we have the S and the S. We have the interphase, DNA replication, and synthesize phase. And the G2 phase, we have the growth and preparation for metastasis, or the second growth phase. So this is kind of anti-tumor or neoplastic drug. We have the alkylating agent, the classification. So for the cell cycle, they do not target any non-specific cell cycle. So it can break the DNA helix strand, thereby interfering with DNA replication. So example of alkylating agent, we have the platinol for the ovarian, testicular, bladder, breast, prostate, head and neck cancer. Cyclophosphamide, the cytoxan for the breast and ovarian multiple myeloma and lymphomas. We have also the paraplatin or carboplatin for the ovarian and lung CA, and bendamustine trinoda for the chronic leukemias. So the clinical pros of alkylating agent, it is hypersensitivity may occur with a late dose of carboplatin. Tumor lysis syndromes with high tumor burden. Assess the BUN and creatinine CBC with differential. It's highly emetogenic. If it's highly emetogenic, it can cause severe nausea and vomiting and can cause dehydration. If oral route is given, it should be administered in the morning. And the mesna is a bladder protectant. It's required for those of efazimide and cytoxan, because there are some part of alkylating agents that can cause bladder cystitis or hemorrhage. So some of the doctor or most of the doctor will prescribe a mesna. So we have a baseline audiogram for high dose. For the ototoxicity monitoring, we have the alopecia, the hair loss. Avoid exposure to cold during treatment with eloxatine or what we call oxaliplatin. Post-treatment, 3 to 4 days, avoid consuming cold fluid and cold air exposure. So this is the health education that we can give to the patient, that they should avoid to drink cold water or exposure to the cold air because it can cause pain for the body or peripheral neuropathies. So for temodar is to avoid exposure and PC prophylaxis in patient also receiving radiotherapy or RD. So for anti-metabolite, it is acting in the S-phase cell cycle specific. Common side effect, myelosuppression, GI toxicity, continuous toxicity, and the route it can be given intravenous, subcutaneous, per oram, intramuscular, intrathecal, intra-arterial. Example of antimetabolite, we have azacitidine for MDS, capecitabine for breast and colon cancer, fluorouracil, or what we call 5-FU, is a colorectal, breast, and pancreatic GI cancer, cytarabine, Ara-C for a patient with leukemias and lymphomas, decitabine or dacogen for MDS, and methotrexate MTX for lymphomas and leukemias. So for clinical pair of antimetabolites, nausea, vomiting is common, renal and liver toxicity, so we need to monitor the laboratories. Gemcitabine or Gemcert, it infused over 30 minutes. Longer infusion time can increase pulmonary toxicity, so we have to watch over on that. So ensure adequate hydration and allopurinol for high tumor burden to prevent tumor lysis. So for anti-tumor antibiotic, it's in the cell cycle non-specific, the target. Common side effect is myelosuppression, GI toxicity, cutaneous reactions, and cardiopulmonary toxicity. The route, it can be intravenous, subcutaneous, intramuscular, and intracavitary. So example of anti-tumor antibiotic, we have the bleomycin. It can be for malignant pleural effusions, squamous cells of head and neck, and cervical and testicular cancer. Metomycin or motomycin is in pancreatic, GI tumor, head and neck, esophageal cancer. The color of this drug is purple. Doxorubicin or adrimycin is a brand name. Breast, ovarian, thyroid, leukemias, head and neck, GI tumor. This drug, the color is red. For doxorubicin, liposomal, ovarian, multiple myeloma in combination with bortezomib. So the clinical pair of anti-tumor antibiotic, it's cardiopulmonary toxicity. So we have to watch over the cumulative lifetime dose. We have to monitor the dose of this patient when receiving. And it can cause cardiopulmonary toxicity. So we have to have initial echo test and pulmonary function test if the patient having this kind of anti-tumor antibiotic. It can cause severe myelosuppression as well. Local reaction can occur at administration site and potential for exacerbation. If we say exacerbation, if there's an occur of improper administration of this medication, can cause damage to surrounding area and can cause infection, and it can cause necrosis as well. And we have to monitor liver function tests. That's why the laboratory is very important for the patients who's receiving chemotherapy. So miscellaneous agent is a part of also anti-neoplastic or anti-tumor drugs. It will act in a various phase of primarily cell cycle. With common toxicity, we have myelosuppression, hepatotoxicity, EKG changes, so we need ECG. If the patient have cardiopulmonary toxicity, the route, it can given intravenous, subcutaneous, intramuscular, and per oral or oral. We have nitrosurias. Cell cycle is non-specific, the target. Breaks DNA helix and inhibit DNA replication. Can cross blood-brain barrier. So common side effect, we have myelosuppression, nausea and vomiting. We have the gonadal toxicity. The route, it can be given intravenous, orally, implantation, wafer also. So example of nitrosurias, we have the carmustine for the patient with lymphomas, BMT, malignant melanoma, and CNS tumor. Streptozotocin, it is for the pancreatic cancer and carcinoid tumor. So we have also plant alkaloid. Under this, we have the capotoxin, the epidopolitoxin, the taxine, and vincal alkaloid. The capotoxin will act in the S-phase cell cycle. The topoisomerase inhibitor 1 can cause double-strand DNA damage, common side effect, myelosuppression, alopecia, and diarrhea. Example of this is irinotecan or Captusar for the patient with metastatic colorectal cancer, and the signs and symptoms, it can be early and late onset of diarrhea. So ferrotoxin will be act in the pre-mitotic phase, the G2 and S cell cycle. Induce irreversible blockade of cell and interfere with topoisomerase 2 and enzyme reaction. Common side effect, hypersensitivity, myelosuppression, the eye toxicity like nausea and vomiting, diarrhea. It can cause hypotension. So example of this is etoposide, BP16 for the testicular, and we have this squamous cell, lung CA, and non-Hodgkin lymphomas. So for the taxane, it will be act in G2 and MP cell cycle, inhibit cell division. Common side effect, hypersensitivity, myelosuppression, continuous neurological toxicity. So vincal alkaloid is an act in late G2 and MP of cell cycle. It will be block the DNA production, prevent cell division, and the route is intravenous. Common side effect, we have myelosuppression, autonomic and peripheral neurotoxicity, and it also known as vesicant. So for the clinical pair of plant alkaloid, we have the majority are vesicant. If we say vesicant, it's very dangerous if it is given improperly. It can cause can cause damage to the surrounding area, and can cause necrosis, and can cause amputation of some part of the body. So it's cause myelosuppression, peripheral and sensory neuropathies, diarrhea, and hypersensitivity potential. So as you see, we have the anti-neoplastic man. This is a graph where the patients can cause the side or toxicity of the chemotherapy. So we have the sign and symptoms, the name of the drugs, and how the toxicity reflect from the body of this patient with the cancer. So we have the classification and major chemotherapies that you will be encountered in oncology department when you're giving or administering medication. So we have the alkylating agent, the antimetabolite, the anti-tumor antibiotic, the plank alkaloid, and many more. So thank you for listening. I hope you get some knowledge from me, and together we can fight cancer. I am Marbini Abdul Singh, and thank you.